Hi, everyone. My name is Dr. Anthony Yee. I'm an orthopedic surgeon that practices here in Seattle at Orthopedic Specialists of Seattle. And thanks so much for joining us this evening. And a big shout out to IRG, who was a wonderful group of physical therapists who I've been working with and have had a great experience and can attest to their dedication to helping patients through the rehabilitation process. So a big thanks to IRG and all the people working behind the scenes to make this happen tonight. So tonight I'm really excited to talk about minimally invasive surgery of the foot and ankle. Um, I'll start off with just giving a brief introduction about myself, and then I'll talk about what minimally invasive surgery is, and then we'll go into some of the advantages of MIS, and then we'll talk briefly about sort of the entire spectrum of MIS, sort of what are some specific examples of minimally invasive surgery, and then we'll talk about what patients are good candidates for MIS. And then we'll delve into a specific example of minimally invasive bunion correction, and we'll go into some of the cool details of it. So briefly about myself, I grew up in Tacoma. My wife and I actually both grew up in Tacoma, and so it's been really an honor to be back in the Pacific Northwest and practicing in the community that we grew up in and had so many good memories growing up. I went to the University of Southern California for undergrad, and then I stayed there for medical school. And then I came back up to Seattle for my general orthopedic surgery residency training just down the street at the University of Washington. And then I wrapped up my training and specifically completed a fellowship in foot and ankle surgery at Harvard Brigham and Women's Hospital out in Boston. And so I'm an orthopedic surgeon by training. So you might be surprised, but I specialize both in non-surgical and surgical care. I'm a surgeon, and I love operating, but my goal is to get you to reach your goals, whether that include surgery or not. And generally speaking, my philosophy is to try everything short of a surgery before resorting to surgery, which is more of a last resort effort. So within orthopedic surgery, I specialize specifically in foot and ankle. I love foot and ankle. I think that the biggest draw for me is how diverse it is and the complexity of problems that there are regarding the foot and ankle. So whether that include trauma, people having injuries and breaking bones, and this is an example, arrows and dotted lines show an example of a ankle fracture with 3 different areas within the ankle that have been broken. And this next picture, I'll show you after surgery, sort of restoring the anatomy and stability of the ankle and holding it all together with plates and screws. I also love treating sports injuries. This next photo is of a Achilles tendon repair. So we're looking back down on the heel of the right heel of an individual who had an Achilles tendon rupture. And I've sort of put the pen markings along the lines of where the rupture was. And you can see how small that incision is, probably just a couple of centimeters, just needing 3 stitches there. And so I've really been loving doing surgery through as small incisions as possible that's still safe and effective. And this has been, for example, one of those procedures that have been really successful. Also, part of foot and ankle is correcting foot deformities. As you can see here, there's a lot going on, including a bunion, and all the toes are sort of out to the side. And also, this individual also had what we call metatarsus adductus. So all the metatarsals in the middle of the foot are sort of sweeping over towards the bump or the bunion there. And this next photo will show you correction of that. This was actually done through MIS approach. Also, a big part of foot and ankle care is treating foot and ankle arthritis. There's a lot of small joints in the foot, and all of them, unfortunately, can develop arthritis. This next slide will show you that's what a healthy ankle looks like. That those arrows are pointing towards the joint space, which is filled with cartilage, and a healthy ankle on the left side. And on the right side, you can see that space is almost gone. So we call this bone-on-bone arthritis, or end-stage arthritis, when the bone is basically grinding on another bone. This next picture will show you one of the treatment options, total ankle arthroplasty, or an ankle replacement, which is often a very successful and reasonable choice for some patients that are sort of at the end of the rope, so to speak, in terms of their arthritis care. Again, we talked about bunions, and also this is a picture on the left of a bunion before surgery, on the right after surgery through a MIS technique, which I'll talk a lot more about later. Cartilage injuries are a big part of foot and ankle care as well. These can happen with associated injuries, like, for example, an ankle sprain even. And with cartilage injuries, there's a lot of different treatment options, and then some of which I've been really excited to be doing through a minimally invasive approach. And so, yeah, I love everything about the foot and ankle. So that's what I specialize in. So what is minimally invasive surgery? So MIS isn't a single surgery. I think of it more as a concept, and that concept being based on performing surgery through the smallest incisions possible with special instruments. But the key being that it still needs to be safe and it still needs to be effective. So how do I perform minimally invasive surgery? So there's two main tools in my MIS toolkit, so to speak. The first of which being arthroscopy, basically fancy word for camera. So the arthroscope is basically just a special camera that we're able to use to look inside small spaces in the body. For example, the ankle joint. So we're able to introduce this camera through an incision that's pretty small, on the order of about 5 millimeters. And then I generally make another incision where you see on the left side there, the medial portal. It says that's where the camera is introduced. And then on the other side where it says lateral portal is where I can place special instruments to perform surgery. For example, up on the photograph A, this is looking into a left ankle joint. So the next photo shows an X-ray to sort of correlate with where this would be in the ankle. So that arrow shows you that dome, that rounded surface of the talus, which is the bottom part of the ankle. And as you can see in the photo A, there's sort of a crater there where that metal instrument is. And that's what we call an osteochondral lesion. And these are injuries that we can easily visualize and treat via arthroscopy or an minimally invasive approach. So that metal instrument is called an awl, and this is showing performance of a procedure called microfracture. The idea behind this is to make small holes inside the bone underlying the cartilage to let the bone marrow and stem cells and growth factors leak out into the area of injury and help heal that area down. So this is just one of the examples of how we can use a small camera and some special instruments to perform pretty cool surgery. So what can you do via arthroscopy? I think a better question is, what can't you do via arthroscopy? Because we're really trying to broaden our horizons and do things and perform surgery that's safe and effective through smaller incisions. And so we can perform so many things like debridement, which is basically fancy words for doing cleanup of the ankle joint or any other joint. We can remove bone spurs. I can remove small tumors in the ankle joint, for example. Also, as I showed before, we can address cartilage injuries. We can also perform ligament repair. For example, just a few weeks ago, I had a patient who had a bad ankle fracture dislocation, and I did an ankle arthroscopy procedure because these higher energy ankle fractures are associated with often having some sort of issue inside the ankle joint, whether that be a cartilage injury or a ligament injury. And I was able to very clearly visualize the ligament injury, and I was able to repair it through those small arthroscopy portals rather than making a big incision on the side. And you can also even perform things like tendon transfers. For example, we often borrow and use a tendon, a neighboring tendon, to try to strengthen the repair of another. But this can even be done through arthroscopy in a minimally invasive approach. Arthroscopy can also be used to aid and assist in fixing fractures. The best way to make sure that a fracture or broken bone is set exactly in the correct position is directly looking at it. And we can use a camera to do that, especially to make sure that the joint looks perfect when we're fixing fractures as well. And there's a lot more, and I can talk about some more in the next slides here. So the next toolkit, in the MIS toolkit, is on the left side is called the minimally invasive burr. So on the top left, that button that looks green, red, and yellow, that's the foot pedal that I use. It's a foot pedal that I use to control the burr. And then the power unit is to the right. And then below it is the handpiece. In that sort of skinny metal portion to the left of it is the actual burr itself. This is a really cool technology. It's based on having a high torque and low velocity so that it doesn't create too much thermal energy, so that there's not a bunch of thermal transfer or injury to soft tissue structures like skin and tendons and blood vessels when I'm operating. But the high torque aspect of it lets me have a lot of power and do even bony work, and I'll talk a little bit more about that. One of the really important parts of this is knowing your anatomy around the foot and ankle, and also using what we call a mini C-arm, which is a very small X-ray machine that emits a lot lower dose of radiation than a standard X-ray machine, and using this as a guide when you're performing surgery with the burr. So we'll talk a little bit more in depth about this, but what can you do with this burr? You can fix a bunion, for example. On the top left is before surgery. The bottom left is after surgery. And the top right also is before surgery, an X-ray. And you can see how this bunion has been corrected. And this is all through 3 or 4 really small incisions that are only a couple millimeters in length, and using this burr to make some cuts along the bone and what we call an osteotomy to correct the bunion. So what are some advantages of MIS? One, as I talked about, these much smaller incisions than through traditional methods of surgery mean that these incisions are only a few millimeters. And to give you an idea, that means usually only 1 or 2 stitches to need to close that incision. It also leads to less scarring. So not only is this more pleasing to the eye, but it's more gentle to your skin. There's less complications because we're not making a huge surgical incision. There's less bleeding, less chance of things like infection. And often there's a much faster recovery. And I'll go into the details of, for example, a bunion surgery, but I let patients start putting weight down as soon as the day right after surgery. And in that same vein, I found that patients that have minimally invasive surgery generally have a lot less postoperative pain. And my main goal is to try to make it so that you're not taking as much pain medications, especially in light of, more recent um, attention and the unfortunate sides of uh, the complications and addiction to narcotic medications. I think it's really key to try to make sure that pain is controlled. And with MIS, patients often don't even need much in the way of narcotic medications after surgery. And then I mentioned it before as well, but oftentimes with MIS, we can get you to start to put weight down on that foot a lot earlier. So what are some other examples? And again, this is going to look very similar to a previous slide, but I think instead of asking what can you do with MIS, maybe the better question is what can't you do with MIS? One of the things I'm really excited is that we're still learning the limits. So we can address bunions, we can address hammer toes, we can do big foot deformity corrections. For example, you may have heard of a flat arch or a flat foot, and oftentimes if patients sort of reach the end of the road in terms of trying everything possible short of surgery, um, sometimes the only remaining option is to do a big deformity correction, and you can perform a lot of that through a minimally invasive approach. Oftentimes, you can even perform foot fusion or foot and ankle fusions. This is an example of a fusion of an ankle. On the very left is the front view, and on the right side is a sideways view or a lateral view. This particular individual had really bad arthritis of the ankle. And rather than using traditional approaches of putting a big incision across the front of the ankle to access the ankle joint, in this case, I was able to just use two very small incisions on either side of the ankle and use an X-ray machine, and also that MIS burr to do what we call a joint prep. And what that is removing any remaining cartilage. And the point of the fusion is to take away the joint and thereby um, taking away the pain associated with arthritis, but that does come at the cost of um, losing motion through that joint. So it is a very careful decision that has to be made together between the surgeon and patient before proceeding with a procedure like this. You can also take down big bony spurs. This is a sideways view, and you can see that red arrow showing that, pointing to that very evil looking spike of bone that we call a bone spur. And then the next slide will show you sort of after taking that bone spur down, and that's just through a very small couple millimeter incision and using that burr. And there's a lot more that we could talk about as well. So who are candidates for minimally invasive surgery? So I like to use minimally invasive surgery for any patient that is an appropriate candidate. And I would say that's the vast majority of patients. But again, it's hard to make a blanket umbrella statement regarding MIS because it's more of a concept. But to note, a lot of patients that are not good candidates for really invasive surgery, which involves really large incisions, they may often are better candidates for minimally invasive surgery. Just to give you an example, that ankle fusion that I shared with you just a moment ago, that particular patient had a lot of risk factors, meaning factors in their health history that made me more concerned about wound healing complications and other complications like infection. So I think it's a good tool to have. I don't think it's not to overstate it and say that it's um, a golden bullet per se to magically heal everything, but certainly I think that it's a very nice option to have in the toolbox, even for some patients that the more traditional, bigger surgeries might be more risky. So we'll go into a specific example of a bunion, but just to give a bird's eye view. So what is a bunion? As everybody knows, a bunion is the bump on the bottom of the big toe that starts to it often worsens in people. And then you can see the photos going from left to right here. There's a lot of different degrees of severity. Some patients never develop symptoms, but other patients do develop a lot of symptoms. And what are some symptoms that patients have? Mainly pain, sort of at the bottom of the bump there, if you will. So other patients will have difficulty with wearing certain shoes and thereby having difficulty performing daily activities. They can also develop calluses in that area from all the rubbing. And some patients even develop breakdown of the skin in that region. So how do we treat bunions? I always recommend starting with non-surgical methods of treatment for a bunion. And these can include options such as changing footwear. And specifically, there can be certain orthotics that can help. Also, switching to a wider toe box shoe. So this is an example of what is not good for a bunion. So high heels and a narrow toe box, and although much less fashionable to some, the one on the right is an example of a wider toe box that creates more room for the bunion so that there's less rubbing. This next device is called a ball and ring stretcher. It looks like a medieval torture device, but it's not. It basically, you create more room for the bump on the inside of the shoe by using this device. You can also try toe spacers. This is a silicone toe spacer that goes in between the big toe and its neighbor to try to help bring that toe back into a more normal position. And there are also other options such as bunion splints, as you can see here. So when to consider surgery? So basically, if a patient has tried everything, has tried a lot of different of those options that we just covered, and they're still having issues with pain or rubbing against shoes or callus formation, that would be the point at which you would consider going forward with surgery. But a side note, it's never for a cosmetic reason alone. Just because surgery, any surgery has risks, unfortunately, and in the absence of pain or dysfunction, my recommendation would be to sort of leave it be. And so what is MIS bunion correction? So basically this involves turning the picture on the left into the picture on the right through very small incisions. The red arrows show you where the scars are from this individual's after this individual's surgery, and you can see they're pretty small. They're a couple millimeters in length, and just involves using 1 or 2 stitches at each of those incision sites. So starting with the picture on the left, and then this next picture here shows that burr that I talked about. And this is being used to perform what we call an osteotomy, or basically just fancy words for cutting the bone. So that bone that is being cut is called the first metatarsal. So this is called a first metatarsal osteotomy. And this next photo is shifting that fragment over to the left so that it's no longer protruding out towards the right as it was in the original bunion. And then the next steps are putting screws. So that first screw has been placed here through the bottom fragment and through the top fragment. That top fragment, we call it the capital or head fragment because that's where the metatarsal head is located. And then there's a guide wire next to it over which I place the second screw to hold the osteotomy firmly in place. And then the final aspect of the MIS bunion procedure is something that we call an achon osteotomy. And this next photo, so that's what we call the proximal phalanx. So there's a phalanx is just that basically a digit, and that bone there is going to be the site of where this next part of the surgery is. So basically what I do is I use that burr to remove a small wedge of bone. And if you imagine that wedge going away and turning the toe over towards the right, that it straightens it out further. And the end product after putting a single screw across to fix and hold it is a corrected bunion here. So this is an x-ray. On the very left is that 2 weeks after surgery. And you might be wondering, that screw on the leftmost screw might look a little crazy because it's in bone and then out of bone and then in bone again. So what happens there? So then the next photo here to the right, that's at 6 weeks. And you can see a little bit of haziness across that. And that's the beginning of bone starting to form across it. And then here, this is at 3 months, this final photo here. And there's certainly an abundance of bone that's bridged across that area and healed down. Just sort of a testament to the amazing healing capacity of the human body there. So just to put it side by side, the small incisions on the left with the MIS procedure, and then on the right, a more traditional bunion correction would involve a pretty lengthy incision there. So what does this mean as a patient in terms of what sort of MIS bunion is? So there's much smaller incisions. There's less pain because there's much less invasive surgery. There's a faster recovery and earlier weight bearing. And so my postoperative protocol is that for the first 2 weeks, I put a special dressing in the operating room and then let patients put weight down as soon as the day after surgery in a short walking boot. So that walking boot is something that just spans from your toes and up to the lower part of your shin. It looks like a mini ski boot, basically, but smaller. And then at the 2-week visit, I take the stitches out, and then I remove that special dressing that I placed, and I place a new fresh one. And you get to continue walking in that boot for another 2 weeks. And then at the 4-week appointment, we get you out of that boot and into a regular shoe with something called a carbon fiber insert, which is a picture on the right. It's a thin, basically, sheet of metal that's a couple millimeters thick that goes inside your shoe underneath the insert that's already in there. And what that does is it just shields your big toe and protects it as it's continuing to heal. And then at 6 weeks, they start letting you do non-impact type workouts. So these are activities like cycling, walking, swimming, elliptical, rowing, yoga. And then at 12 weeks, you're cleared to start impact type activity. And so that's MIS in a rapid fire sort of nutshell, and some of the details of what bunion surgery are like. And I really thank you for your time. It was really fun getting to talk about this subject with you all.
And we're going to begin our next part of the presentation. I'm Amanda Rixey. I'm a physical therapist, and Rachel Byrne will also be joining me for this presentation. And we both work at IRG Center for Structural Medicine in Ballard. And we're just going to kind of go through our approach on different forms of rehab, kind of what we do a little differently, and then we can open up questions too at the end here. So we'll discuss the importance of rehabilitation, either pre or post surgery, or conservative care if surgery is not required. We'll talk about that prehab before procedure. Then like I said, we'll talk about maybe things that we do a little differently than you would see at a more traditional physical therapy clinic. Rachel will discuss how OT can be offered and what she does differently after surgery, and then how surgery affects the person as a whole, because we are very big on patient-centered care. So when we talk about physical therapy specifically, it's really important to address kind of what are you coming to PT for, right? So we really need to define what are those primary impairments that involve that tissue and lesion. So like just Dr. Yee had described, if it's a bunion and he did a bunion procedure, we are looking at the bone that was fixed, right? But also the joints and the capsules and everything around that. So based on what was involved or what the issue is and what maybe we see impairments in, it could look like the bone, the muscle, fascia, nerves, tendons, ligaments, etc. And then I think this is probably the most important piece of rehab, even though we always think about, okay, I'm just going to work on treating the main thing involved. It's the secondary impairments that involve multiple body systems and regions. And these are all those compensations that we talk about, all the joints next door, basically, all those different systems that might get involved, besides just the bone that was cut into, right? So we talk about musculoskeletal, so our muscles, our bones, etc. The peripheral and central nervous systems are something really big we see specifically at our clinic. We have a lot of patients who have maybe ongoing chronic nerve symptoms that may be also related to some of the foot deformities, for instance, that they've had for a long time. Then there's the neuropsychological system and understanding how the whole side of psychology and mental health can influence a lot of these symptoms as well. And then cardiopulmonary, because your feet are really, designed to help us walk. So if you're not walking, right, then you have a whole different picture of what's going on in terms of heart function, breathing, endurance. I think it's really important to talk about the proximal area. So when we talk about the foot, we just look above it, right? So the knee, the hip, the low back, and the thoracic spine are really big areas. I don't think I've ever met a patient post-operative foot or ankle surgery that doesn't have, hip weakness or some form of other compensation going on. Because, if you're in a boot or cast at some point, even just having a little height difference there can maybe throw off your pelvis, or you're in a little bit of pain for so long, your body starts adapting and moving just a little differently can really throw things off. So we definitely take a look at that and really kind of dissect those different movement patterns. And then there's also a whole combination of having that secondary even tissue involvement as well. So like what I was saying, so it's not just maybe the bone, but now we're talking about retraining all the foot muscles and all the little things like the idea of people like picking up marbles with their toes, things like that, the fascia, nerves, tendons, ligaments again. In terms of the importance of rehab, it's very important to look at a graded approach to returning back to whatever it is you want to do. And that's going to look different for every single patient. And it's very important to identify, like day one, what is it that you want to get back to, right? And that really is how we're going to tailor exactly what we do in every session. Because yes, you want to get back to walking and everything like that, but I would like to get back to being able to, play fetch and swim my giant Newfoundland dogs, right? I have to be able to walk a 140-pound monster, basically. I can't do that if I don't train specifically for that, right? So we want to make sure it's within Dr. Yee's guidelines, right? Like how he talks about, at 6 weeks, you can start some basic stuff. And then at 12 weeks is really when you can start that impact. We very much respect that, and we want to respect the healing process of the body. And you don't want to overload it too soon, because then you end up with other injuries, but you also don't want to underload it and never get better, right? So it all kind of depends on a very graded fashion where we're constantly assessing, reassessing, and seeing what's up. And then, like I said, it's all dependent on your goals. If you're an athlete, I used to work mostly with ballet dancers, and I used to work for the Kansas City Ballet. And that return to activity looks very different. I will see you till the very end, right? Until you are able to do everything you want to in that activity. If you're an athlete, you're running, you're jumping, you're doing all that stuff, and if that's not your thing, right? I'm going to get you cross country skiing. I'm going to get you, just like I said, walking your dog, whatever that looks like. It has to be very specific to you. And then when we talk about prehab, I think that's kind of a newer concept kind of over the last 10 years in rehab. It's the idea of optimizing your current function or kind of just getting the understanding of what my body has to go through with this procedure, and then kind of taking that knowledge so you can apply that afterwards, right? And so this can be months before you even get a procedure, and like, okay, maybe I know I'm going to have an ankle fusion at some point, but like, let me work on all these other compensations I've built up, and then I'm ready for my procedure. Or sometimes I've just seen patients, a week before their surgery, and all we do is kind of just have a sit down discussion of, okay, what does that even look like? What do I need to do to adapt my house? What kind of equipment do I need? Who do I need helping me? Maybe we can go through some of your exercises. I can teach you how to use a walker. I can teach you how to use crutches, whatever that looks like. Often just having that appointment just makes you feel way less anxiety, way less stress, so you know exactly what you're going to get into. And then, we also talk about, how extensive that rehab is after a surgery. And it's important to be aware of that, before you go into that, right? Because if you don't do all the exercises and all of the stuff you're supposed to be doing following the procedure, maybe the procedure outcome isn't exactly what you wanted in the end. And then just like I said, just knowing all those different stages of recovery, pre-op, immediately afterwards, and then beyond, it's all very different there. And just having all your questions answered beforehand, I think, is extremely important. And then here's some kind of like basic stuff that we do a little differently here, not just with the physical therapist, but also with the occupational therapists at our clinic specifically. We have manual therapy techniques that we use very heavily, performed by residency and fellowship trained clinicians, which kind of sets us apart from maybe other clinics. I perform Pilates specific rehab. So I use all the different Pilates equipment, and I have prior training in that. And you can really start specifically with the foot and ankle, going through a lot of the range of motion in a more offloaded, safe position, which is really crucial for getting that strength back early on. Because oftentimes, like if you're training, for instance, like a heel raise, the body's not strong enough to just stand up and start doing heel raises, right? So if maybe you put someone on the Pilates reformer or different machines there, you can actually start the strengthening process earlier, in a more functional, less pain, kind of a better environment there. The other thing about Pilates that's really cool is the more research that's coming out is all about kind of neuroplasticity. So how our brain is able to change, right? We call it plastic. So it's really good for someone who's never done Pilates to kind of get onto the equipment and learn a whole new task. It's novel. And so the nervous system actually is allowing your body to learn these things much quicker than maybe unlearning an old pattern like walking and just trying to dissect specific patterns of your walking. So it can be a really nice adjunct, especially for someone who's had an issue for a very long time and they have all these old compensations and habits, kind of learning something new there. Rachel will talk to you about bone and tensegrity medicine. Another really cool thing about our team at IRG, I do a little bit of this myself, is the on-demand physical therapy piece, where we can come into your house or your home or apartment gym, and we offer that service usually like immediately post-operatively. And I've just found that amazing, especially, it's like 2 days after surgery, the patients are like, I don't know what I need to do. Like, I'm just, helping modify their home setup. We actually design the exercises around their stuff. It's not just what you saw in the clinic, right? I get to see who's around them. I get to see their dog, the Newfoundland crawling all over them. And we talk about safety things. And just getting to meet their family and the caregivers who are helping them out is huge. And it's so helpful in progressing patients there. The other thing that our clinic also offers that we have some training in is also blood flow restriction training, which I found more for maybe further out cases, patients who, I call it kind of like the floppy calf syndrome after surgery, they just don't get that strength back. And so you can use blood flow restriction, which is kind of a tourniquet device, and it has this individualized pressure that you find for your body. And then you're able to work out at a lower capacity, but it feels much harder. And so you're able to train someone who maybe doesn't have that strength in a harder fashion. And that specific kind of tourniqueting of the blood triggers the growth hormones to be produced. And that's what really is important with BFR. It's all about that and getting muscle growth fast. So it's really good for those cases that just aren't really responding to the typical type of strengthening you would normally find.
Good evening, everybody. I'm Rachel. My last name is Byrne, and I'm an occupational therapist here at IRG Center for Structural Medicine. And I'm really excited to see the evolution of surgery, because I find the minimally invasive, the more minimal we can go, the better. So I'm sort of an out-of-the-box occupational therapist, because we really look at the whole body. We look at the whole structure. We look at the whole person. So you might be kind of wondering, what can an OT offer after surgery? And even with the minimally invasive ones, sometimes there's manual therapy needs for any tension patterns, like Amanda mentioned, these compensation patterns that develop. Restoration of sensation or perception. So a lot of times when people have chronic deformities or a hammer toe or a bunion, they sort of might dissociate from that foot if it's been really painful, or if it has to do with an old trauma. So we just like restore their body's perception of that foot and ankle. And we can reduce tension in associated areas of dysfunction. So we'll sort of look at the connective tissue that is leading into the foot and ankle, and just look at those longer lines of connective tissue and longer chains of muscles to see and question, hey, why did this happen in the first place? Like, what tension compression forces are off that caused this to happen in the first place, and just really looking at the system as a whole. And then working on overall nervous system regulation. So a lot of times with an injury, with a trauma, with a chronic condition, or with a surgery, it can cause us to get stuck in our fight or flight sympathetic nervous system. So a lot of times with my clients, I'm just working on helping people get out of that fight or flight state. Whether they've had surgery or not, a lot of us are needing that right now. So occupational therapy really looks at, like I said, holistically. We kind of have like a bird's eye view. So there's compensation patterns. So after an injury, even if you're going to be able to avoid surgery, you're going to be moving slightly differently, kind of favoring it, moving differently through your life. After surgery, you might also be moving in a slightly different way during those really basic repetitive tasks, or even at those higher level tasks. And altered tensegrity just means those tension compression forces that are holding us up in space can be altered either with an injury, with a chronic condition, or with surgery as well. So OT, we're really trying to just take that bird's eye view. We also really like to pay attention to sensation, making sure that somebody has restored all of their sensation. We see a lot of chronic conditions, either pre or post-surgery. A lot of times with the foot and ankle, people have altered sensation, either because of, like I said, dissociating because it's been painful for so long, or just because of that soft tissue injury. But there's less of that with minimally invasive surgeries. And then we, as occupational therapists and as a team at the Center for Structural Medicine, we also like to think about the adjustment to injury. You know, how is the person handling this mentally? Do they have support to, you know, go through this right now? How is the injury or surgery affecting their overall health and well-being? So the real roots of occupational therapy comes in here because we really want to make sure that people have a self-care plan to sort of get through this and be their best self in the end. So that's also what we specialize in as OTs, is making sure that the person has a self-care plan to be able to take care of anything that's come up from the surgery or from the injury itself. So I think we'll kind of open it up to questions, and I'll sort of hand it back to Amber.
Great. Yeah, if you have a question, feel free to type it in the chat and we'll hang out here for just a couple more minutes. And if you have a question that gets posted in the chat after people log off, we'll be sure to connect you with somebody who can answer those questions for you. So feel free to type in that chat box and we'll answer any questions that come in. Okay, this question might be a good one for you, Dr. Yee. It says, can podiatrists perform MIS? What are the main advantages and disadvantages of a podiatrist versus an orthopedist physician? Oh, and I think you might be on mute, Dr. Yee. You might need to unmute.
I was just saying, yes, so that's a great question. Yes, there are some podiatrists who perform minimally invasive surgery. In terms of the difference between a podiatrist and an orthopedic surgeon, I think that very much lies in the difference in training. So a podiatrist goes to podiatry school, so they're obtain a degree, and they're a doctor of podiatric medicine. So they've focused on sort of foot care through that time, and they generally complete a residency also for a few years to hone their surgical skills within the realm of the foot. An orthopedic physician goes to medical school for 4 years, so they're an MD, medical doctor. So they've sort of learned the ins and outs of the human anatomy and the general principles of treating not just the musculoskeletal system, but all the systems of the human body. And then after medical school, they've completed 5 years of general orthopedic surgery training, which encompasses not just foot and ankle, but for example, joint replacements, sports injuries, the spine, pediatric care. And I think that, as an orthopedic surgeon, I'm very grateful to have had that wide range of training, because I think that it's really important to consider the foot as a part of not just the foot and ankle, but as a part of the entire musculoskeletal system. It's very much related, as Amanda and Rachel pointed out. We call it the kinetic chain. So it's, if one part of the system is off, something downstream is probably going to be off as well. So I think it's really important to consider injuries and pathology of the foot and ankle in the entire context of the entire musculoskeletal system as it relates to the knee, the hip, the back, the spine, for example. And I think one other aspect that I'm really grateful for having a very broad training in orthopedics is that there are principles that apply from other aspects of orthopedics that apply to foot and ankle surgery. For example, foot and ankle, I think, out of all the subspecialties, is sort of a mix or amalgam of all the subspecialties. So they cover, sports type injuries, trauma, fractures, deformity correction, joint replacement. So I think because foot and ankle is so diverse, I feel very fortunate to have that a very broad training.
Thanks for answering that, Dr. Yee. It looks like we have another question that's coming through the chat, so we'll just wait for that one and see if we can answer it. Okay, so this question says, I suffered a complete Achilles rupture 4 months ago. My ortho went with the non-surgical route. Now here I am after 4 months of PT and the MRI shows complete rupture still. Is MI surgery even an option?
Yeah, that's a good question as well. So, both surgical and non-surgical management of Achilles tendon is a very reasonable option. I think it really depends on the specific patient, and I'm sure that you had that conversation with your orthopedic provider. And in terms of, so it sounds like 4 months out from the injury, and you had an MRI, and it's still a complete rupture. I would, if you were my patient, I think I would really want to explore sort of what your functional level is right now, what your goals of surgery are, or excuse me, what your goals are in terms of sort of who you are as a person. I'd want to get to know you. And then in terms of someone who is this far out from surgery, I would probably lean away from minimally invasive surgery, depending on what the MRI looks like and sort of what your foot and ankle look like on examination. But the reasoning being is that if there hasn't been healing across the ends of the torn Achilles tendon, my hunch would be that it'd be hard to get healing to occur between bad tissue on one end and bad tissue on another end. So I think that probably I would probably, without knowing too much about the case, would probably shy away from minimally invasive surgery in this particular case. But again, it would depend on the details. But in terms of with the information I have here, I think that's what I would lean towards, not doing minimally invasive surgeries, so I can really be confident that I'm looking at the quality of the tendon, and if there's poor quality tissue on one end and poor quality tissue on the other end, I'd want to debride or clean that up and then bring the healthy ends together so that I would be more confident in healing. And there might be some other sort of supplementary procedures that would occur at that same time. But again, I will put the disclaimer that I would need I would want to get to know some more details before definitively saying one option or the other.
Great. It looks like we do have a question maybe for Amanda and Rachel. What is the difference between an OT and a PT?
Yeah, I think Rachel and I can kind of tag team this one a little bit. Historically, I think they're formed kind of in two different entities. Now, I feel like there is more of a mesh and a lot of overlap between what our professions do. There's obviously things that Rachel can do that I can't do, and vice versa, right? But I think the biggest thing in terms of like physical therapists right now, we look at what impairments we're talking about objectively. So in terms of body structure and function, and then we look at kind of a whole performance level activity limitation as well. And so kind of how do those two go together, and then how can I improve on the body structure function region to make that performance activity level better and back to what you want. And so that's kind of where PT works around, and it's a whole different, you can work in wound care, you can work in orthopedics, you can work in neurological settings. I mean, it's a very vast setting, but in terms of what Rachel and I do, there's a lot of overlap. Mm-hmm. And then Rachel, you can kind of tag team on top of that.
Yeah, thank you. I find this question very difficult because I have a lot of training on top of the occupational therapy degree that makes me kind of a unique occupational therapist, even within IRG. So within my own field, I have a unique set of skills with sort of a bunch of other letters. After my name. So, but I would say occupational therapy, where we look at the person, the environment, and the occupation. And occupation in the really broad sense of the word. So, are you able to put your shoes on or run a marathon? So, like, however you occupy your time, anywhere along that spectrum. So, can we adapt the person, the task? Can we come up with a tool? You know, can you use like toe separators to help somebody with pain? So it's all about these basic activities of daily living. How can we make those easier and help you from a really holistic view become like the best version of yourself, basically? We're really concerned with those like really basic activities that we sort of take for granted until we injure our foot.
Those are great answers. Thank you both for taking that. I think right now we'll probably wrap things up. I just want to respect everybody's time here on the call. And I do want to thank everybody for presenting tonight. Dr. Yee, Amanda, and Rachel, thank you so much. And if you do have any questions, you are welcome to email events@irgpt.com, and we will connect you with the information that you need. So feel free to do that. And we'll see you next time.
Thank you, everybody.